case, if someone has brought a case for us, and 2 discussants, ideally one identifying as a man and one identifying as a woman. Ravi has already volunteered, fantastic. So ideally someone identifying as a woman to discuss along with Ravi, and then a case, and we'll get going. Who'd like to join us? Some made-up cases. Does that mean not real cases, or? You mean composed cases from faculty? Okay. Oh, not real. No, we'd like to do a real case if that's okay. Yeah. Who'd like to discuss with Ravi, and then does anyone have a case? So reasons you might not want to discuss. You might think, I have neurophobia. I don't like neurology. I don't know any neurology. That's a perfect reason to discuss, because you'll get a chance to learn some neurology. You might be saying, well, I want to, but I'm not sure I know all the words in English. Well, guess what? We have Spanish speakers, Portuguese speakers, French speakers, so many speakers of so many languages. So we will be able to help you out if need be. So we have Ravi. Thank you, Boris. We'd like to have one volunteer discussant who is identifying as a man and one as a woman, ideally. Anyone else like to discuss? And does anyone have a case? Every week I say the same. At 10, people say, he's still going, it's running over. But it's because we spend 10 minutes waiting for volunteers. It's so fun. I see Kiara smiling. She knows how fun it is. She's presented cases, she's discussed cases, she's written up cases from this morning report. I can discuss, but rusty on neuro, perfect. Rusty on neuro is no problem. Happy to have you, Lauren, fantastic. And do we have a case? All right, Gabriella or Kiara, do you have a case you might be able to pull from your magical infinite files of amazing neurology? Or is Valeria here? I'm not sure who has amazing cases. Mohammed has cases. Anyone?
I have a case, and also if someone else wants to participate.
Oh, Rebecca says if we can give her 2 minutes. Sure, Rebecca, we'll give you 2 minutes. Ravi and Lauren, do you want to introduce yourselves? Let us know where you're joining us from while Rebecca finds her case, and then Rebecca can introduce herself and we'll get off to the neurological races here.
Yes, my name is Ravi Patel. I'm calling from India, New Delhi.
Okay, fantastic. And if you don't mind telling us where you are in your training, Ravi?
Yes.
In terms of what year?
30 years in medical school.
Third year medical school in New Delhi. Okay, thank you for joining us. And I know you've discussed neurology case before. Glad to have you discussing. For those who were reluctant today, look, Ravi liked it so much he wanted to do it a second time. So that's fantastic. Lauren, do you want to introduce yourself?
Hi, I'm Lauren. I live in Newport Beach, and I'm a fourth-year medical student at UC Irvine.
Fantastic. You're a neighbor down the Route 5. I'm up in Los Angeles. So great.
Oh, awesome.
Thank you. Thank you for joining us from Irvine. And Rebecca, how are you? So sorry, can't find it. Okay, someone else have a case?
Guys.
No worries.
Sorry, I have a good one, but I can't find the write-up, and I don't want to.
No worries. No worries.
Give you half a case.
Come back next Tuesday or the Tuesday after, and we'll be happy to have you present your case. We're here every Tuesday. So Robert, a neuro case recently, still a work in progress. We have had some that sort of end without a final diagnosis, which I always see from people's faces, they feel is a little bit of a letdown. So without revealing too much, do you have a final diagnosis, Robert, or not quite yet? No final diagnosis. Let's bring it back. Again, many cases don't get a final diagnosis. That could still be an interesting discussion, but as we're learning clinical reasoning to know sort of where we went right, where we went wrong, I think at this stage of learning is helpful to know. Okay, Gabriella, looks like you're up. Would you like to present your case? So just start with just the chief complaint here, and then myself, Ravi, and Lauren will take a crack at it in as few words as possible.
Okay, so the chief complaint is involuntary movements in the left hemibody.
Involuntary movements, great. Lauren, you hear involuntary movements. What starts running through your head?
Involuntary movements, I guess I start thinking about seizures, different movement disorders, curious about the chronicity of the symptom.
Fantastic. So great. When you first hear involuntary movements, I love that you started with seizure, because some people say, oh, it's a movement disorder, right? It's going to be a tremor or myoclonus, chorea, bullism, something like this. And you backed up one level, which is great to say these involuntary movements, they could be seizures. They could be a movement disorder. There are other things we can add to that list too. And you said on the other side, we're going to want to know the time course, right? So those of you who've been with me before on Tuesdays know I like to say that E equals MC squared of clinical reasoning in neurology is differential diagnosis equals localization and time course. So the time course piece, knowing is this sudden onset of involuntary movements? Is this sudden and transient, sudden and sustained? Is this acute but not sudden, meaning over hours to days? Is this subacute? Is this chronic? Those are all going to help us. And I'll say a few more things. Let me hear what Ravi has to say here. So involuntary movements, Ravi, what's coming to your mind?
Yeah, what's coming to my mind is I'm going to convert involuntary movements as tremors. So what's coming to my mind is Parkinson's and myoclonus, like jerks. Or I mean, she already mentioned Huntington disorder. So yeah, myoclonus and jerks and tremors.
Great. So you're starting to list some of the types of involuntary movements. So that's fantastic. So when I think about involuntary movements, I start with some of the same things you did. One possibility is this seizure, right? Abnormal electrical activity in the cerebral cortex causing involuntary abnormal movements, motor seizures. Those could be tonic, tonic-clonic. Those could be myoclonic, as you said. So seizure is one possibility. Another possibility is that this is a movement disorder, and you listed many of those. And so movement disorders can sort of fall into two broad categories: hyperkinetic movement disorders and hypokinetic. Hypokinetic is basically Parkinson's, the bradykinesia and rigidity of Parkinson's. And the rest are the hyperkinetic. Parkinson's has one of those, right? So there's tremor, which you mentioned, which is an oscillating, usually rhythmic oscillating movement, right? Then there's myoclonus, which is a lightning-like jerk of one part of the body, so fast, faster than you could do it voluntarily. And that should be distinguished from clonus. People confuse those. Clonus, if you push on the patient's ankle or foot and the ankle starts quivering, that's clonus. That's a sign of hyperreflexia. Myoclonus is something else. There's tics, right? As you can see in Tourette's. So those are more complex involuntary movements preceded by a premonitory urge and usually followed by relief. The patient feels sort of almost a compulsion to do the movement. And once they make that movement, vocal or motor, it's resolved. There's chorea, which is like choreography, a dance-like movement, sort of random flowing movements. And chorea exists on a continuum from athetosis to ballism, like hemiballismus, which is often on the USMLE subthalamic nucleus, right? It's not that common in practice, but chorea, athetosis, ballism is sort of one category of movement disorder. And then dystonia is sort of the sort of twisting movement into a fixed posture. That's another hyperkinetic movement disorder. Am I missing any? Tremor, myoclonus, ballism, chorea, athetosis, tics, dystonia, maybe others will come, but those are some movement disorders. And what's interesting in movement disorder, so in neurology, we often say, where's the lesion, right? If it's weakness, we're saying, is it corticospinal tract? Is it brainstem? Is it spinal cord? Is it nerves, nerve roots, muscles, etc.? For movement disorders, it's not so much about where the problem is, because most of these are related to circuits involving the basal ganglia, but it's really important to figure out the type of movement. And by looking at these movements, sometimes it's obvious and sometimes it can be tricky. Is that a tremor or is that lots of fast myoclonus? Is that a tic or is that a choreiform movement? And once you can figure out what type of movement it is, your differential diagnosis sort of follows from that. And each of these has a really long differential diagnosis, but I break it down into a couple of categories. Basically, neurologic, systemic, or drug toxin induced. And so for every movement disorder, that's how I sort of start to think about it. And within neurologic, I think of two broad categories for each one: structural lesion causing the movement disorder and neurologic disease causing the movement disorder. So depending on what the movement is, we can go down this pathway, but just to take chorea, for example, not that common to see, but if you saw hemichorea, one side, sudden onset, you might think of a structural lesion in the contralateral subthalamic nucleus, right? So that's a structural lesion that can do this. As Ravi mentioned, Huntington's chorea, right, is a neurologic disease with degenerative disease with chorea as one of its main features. There are systemic conditions that can cause chorea. Hyperglycemia is one, not a systemic condition, but a state of the body. Pregnancy, you can get chorea gravidarum, a chorea that comes on in pregnancy. Lupus can cause chorea. And then there are medications, drugs that can sometimes cause chorea. Cocaine can sometimes cause chorea and acute intoxication. So for me, if I see the movement disorder, I'm trying to figure out what movement disorder that is. And then my differential diagnosis is neurologic, systemic, drug-induced. And under neurologic, I'm thinking about whether it is a structural lesion or whether it is a neurologic disease, like a degenerative disease or a, quote, movement disorder disease. And what's cool is that each of those movement disorders has a particular differential that sort of falls into these categories. And after this, I can post in the chat a table I've made that has some of this broken down. So those are some of my thoughts building off some of your thoughts. So what we're going to be keen to figure out in this history, as you both mentioned, is what type of movement this is. And a picture is worth 1,000 words. So during the history, we're already doing the exam, but Gabby will describe this for us. And the time course, if this happened instantly, we might be worried about a vascular lesion. If this is happening sort of subacutely, we might be thinking about a infectious or a tumor type lesion affecting the basal ganglia. If this is happening chronically, we might be thinking about a degenerative condition. But the unilaterality here, right, makes us think on a first pass like it might be something structural. Well, that's not perfect. The tremor of Parkinson's disease often begins unilaterally and remains asymmetric. The abnormal movements in cortical basal syndrome, such as the alien hand phenomenon in myoclonus, are often unilateral and remain asymmetric. And then although you'd think a systemic condition would often cause bilateral movement disorders, that's often true, but for example, hyperglycemic chorea is often hemichorea for unclear reasons. You get hyperglycemia, it's obviously going through all the brain, but you get a sudden onset of hemichorea in that context. So as you can see, I'm very interested in movement disorders. I find them fascinating and have a very interesting phenomenology, a very interesting differential diagnosis. And then for us in neurology, they're often very treatable, which is gratifying as well. So, okay, Gabby, tell us how old this patient is and some other details beyond these 5 words so we can get a better sense of what's going on.
Okay, this was a great discussion. So she's a 68-year-old female that presents with acute onset choreiform movements in the left upper and lower limb. She didn't have any fever, weakness, weight loss, or other complaints. She has never had this symptom before, and it didn't change, either got worse or better since the acute presentation. They are still present during sleep, and she doesn't identify any alleviating or exacerbating factors. Previous medical history. She has type 2 diabetes for more than 5 years and hypertension. Medications are hydrochlorothiazide, metformin, losartan, nimodipine, omeprazole, and how do I say AAS, ascorbic acid, is that correct?
Vitamin C, yeah, okay. Or aspirin?
No, aspirin, yeah, sorry.
No problem.
Thank you.
Thank you.
And familial history, social history, and allergy or negative.
Fantastic. Okay. I think we started with you first last time, Lauren, so I'll ask you, Ravi, what are you thinking about hearing this additional history?
Yeah, hearing additional history, she's 68, female with a history of diabetes and hypertension. those are risk factors for atherosclerosis and vascular conditions. Given that the onset, the timing is acute, so I'm thinking of for cerebellar lesion, like a stroke. The location is left upper and lower limb. So I'm trying to localize a lesion in the vascular territory. So upper and lower limb. I know lower limb is MCA, middle cerebral artery, but upper limb, but that doesn't explain me the movement though. Usually movement is cerebellar lesion. She doesn't have any fever, weight loss, so no infection. I'm not seeing any infection because there's no weight loss. There's no inflammation, no fever, no weight loss. She never had these symptoms before. Given that, that translates that to me like acute. So there's a new. So given that my differential diagnosis, the probability to be more in the vascular now, like a stroke. Yeah, those are my thoughts.
Great thoughts, Ravi. So whatever the condition here, whether it's weakness or ataxia or chorea, whatever you've heard of a sudden onset presentation in a patient with vascular risk factors, we have to be thinking about stroke, right? We have to be thinking about stroke. And stroke could be an ischemic stroke, right, from blockage of a blood vessel, either due to local thrombosis from vascular risk factors or embolism from the heart, from other risk factors. We can also think about a hemorrhagic stroke, right? This patient has hypertension, which is the main risk factor for intracerebral hemorrhage, also on aspirin, which doesn't increase the risk very much, but is there, right? So this patient could have had a hemorrhage. And there are some factors we might ask about on the history that can sometimes help us distinguish ischemia from hemorrhage as the cause of the acute stroke, but they're not that specific. So for example, patients with a hemorrhage are more likely to present with headache at presentation. So some patients with ischemic stroke will present with headache also. Patients with hemorrhagic stroke are more likely to present with altered level of consciousness at presentation because of the mass effect of that hemorrhage, whereas ischemic stroke can swell over the first few days and cause depressed level of consciousness or even herniation. Hemorrhage can cause that instantly because it has instant mass effect, right? A very high diastolic blood pressure, nausea, vomiting presentation. People have tried to make sort of scores here. Obviously, CT is what you need to figure it out, but not everyone in every place has access to a CT. So there are some decision rules that try to help us, but headache at presentation of acute onset focal deficit, depressed level of consciousness, extremely high diastolic blood pressure, nausea, vomiting, depressed level of consciousness at presentation are all suggestive of hemorrhage rather than ischemia. So we haven't heard about those here, but a small hemorrhage might not have those, and certain ischemic strokes can have those. So I agree with you, we're thinking about stroke, and then our next thought should be, is this ischemic or hemorrhagic? Because if it's ischemic, we're on the clock, right? We might be able to give this patient TPA, or might be able to do a catheter-based procedure. And if it's hemorrhagic, obviously we're not going to be able to do any of those things, and we'll be interested if the patient has a coagulopathy or something like that we need to reverse, or in some cases even think about evacuating the hemorrhage depending on its size and location. The other thing you mentioned was, so that's the time course, and I think we're narrowing down on stroke, that's right. And then you said it's pretty interesting here that acute presentation, so far you hear vascular risk factors, acute presentation, neurology, you're thinking stroke, right? But then you hear that the acute onset phenomenon is chorea, right? You didn't hear hemiparesis, you didn't hear aphasia, you didn't hear neglect, some of these sort of more classic stroke presentations. You heard chorea. Now you mentioned the cerebellum. Cerebellar lesions cause abnormal movements in a sense, they cause ataxia. Movement disorders textbooks I found often have a chapter on ataxia, but I don't really think of it as a movement disorder. I think of it as a disorder of coordination. I know that sounds like splitting hairs, but patients with a cerebellar lesion will have ataxia, which is an inability to perform the sort of precise movements, because the cerebellum, we can talk about maybe another time, I think we have talked about before, sort of involved in coordinating our movements, right? So when you do this finger nose test, if you were to do a slow motion of a patient with cerebellar lesion who has ataxia, we know that there's a tremor, and that tremor is usually perpendicular to the plane of movement, and that tremor is not there when the patient's at rest, but it comes out with action. And it worsens with intentional action, so called a kinetic tremor, and in particular an intention tremor. So normally you see this, right? But if you were to slow it down, you'd see at the nose, there's a lot of tremor because there's precision needed and the cerebellum is needed for precision. But during the plane of movement, when precision is not needed, the tremor is not too bad. And then as it gets to your finger, it really amplifies again, right? So cerebellar ataxia has that particular feature. And we're not hearing about ataxia, we're hearing about chorea. Now, the patient probably didn't present to Gabby and say, I have acute onset choreiform movements, but maybe uncontrolled movements. And then Gabrielle and her team thought they looked choreiform. So Lauren, we've talked about the acuity here and what this could be. Any thoughts on the fact that the acute presentation is choreiform, or anything else you wanted to mention regarding the case so far?
That was awesome. I'm super impressed. The most important thing to try to rule out first is stroke and vascular causes. I think just a quick glance at the medication list, nothing shouts to me as being likely to be responsible for these movements. And then thinking about systemic causes, I'm not exactly sure if these things can present acutely, but you know, she's an older age for Huntington's, it would be expected, but I vaguely recall something called senile chorea. I know Wilson's disease can sometimes cause chorea, and you know, other endocrine and metabolic issues. But I agree that vascular is the first thing to work up.
Fantastic, great thoughts, right? So the acuity really does narrow things down. So for me, when I'm thinking about neurologic presentations, I like to divide acute into hyperacute and acute, because the differential diagnosis for something that's truly sudden is different than that sort of emerges over hours to days. So if we're talking truly sudden, this is stroke is one of the main things on our mind here. Let's say that we had just heard these are involuntary movements. We don't know yet that they're choreiform. Lauren, what other sudden things can you think of in neurology where the patient is normal and then an instant later is abnormal? So stroke is a big one. What else would you put in your hyperacute sudden neurology differential?
Let's see, seizure. Do you mean for movement issues?
Even not even for movement right now. Just sudden neurology. So seizure, perfect, is the other big one, right? And the patient could present with the abnormal movements, or if the patient has the seizure and it's brief, which most are, and you see them then after, they could be postictal, and they could have a postictal Todd's paralysis or some postictal twitching in the limb or limbs that were seizing. Anything else, Lauren, that you'd put in the sudden category, sudden neurology, even not choreiform, that's a tough one, but sudden categories of sudden neurologic deficits?
Vascular seizure, potentially infectious.
So infectious, usually not sudden, right? But definitely acute. So a patient with a neurologic infection, what neurologic infections might you think about?
A meningitis or encephalitis.
Perfect. Yeah, so meningitis, encephalitis definitely present acutely, and that's why I like to make this division, right? They tend to come on over hours to days, right? The patient just doesn't suddenly have all of a sudden the explosion of meningitis, right? And if you think of when we get the flu or a cold or something, you sort of have the night before sort of the sore throat, right? And you feel tired, and the next morning you start to feel a little sniffly. It has sort of an arc to it over hours to days. And meningitis, encephalitis as well. I think of them as acute, but not sudden, and true of any systemic infection. Bacterial and viral infections tend to be in my sort of acute, not mine, any acute category, and subacute sort of fungal, tubercular complications of HIV, more sort of subacute to chronic infections.
There's also intoxication. Like intoxications, medications, withdrawals.
Absolutely. So in any category of neurologic disease, we have to think about toxic, metabolic, and drug, right? So for me, sudden, my list is stroke, seizure, toxic, metabolic, and then migraine. Might not think of it, but the aura, in the 20% of migraineurs that have aura, or the headache itself can be pretty sudden in onset. And about 1 in 10 people have migraines. So statistically, 5.8 of us in this room have had a migraine or are going to have one. And we'll note that it's sudden in onset. And then trauma, usually obvious from the history, is another sort of hyperacute neurologic situation. But that toxic metabolic is an important one, right? So as I mentioned earlier, for every movement disorder, we have this sort of, there's neurologic diseases like Huntington's, Wilson's, you mentioned, we'll talk about those in a moment. There's structural neurologic lesions that can cause that movement. Then there's systemic conditions, and then there's toxic drug, et cetera. So for chorea in particular, for diseases, you mentioned Huntington's disease, that wouldn't present acutely, right? Those patients will present chronically. It's a degenerative disorder caused by a CAG repeat in the chromosome, I think it's on chromosome 4, the Huntington gene. And because of that repeat phenomenology, it causes anticipation. So someone in the chat I saw said, oh, too old for Huntington's. I guess if you didn't have that many repeats, you could find yourself presenting later in life, but usually there's a sort of psychiatric piece at the beginning as well and wouldn't present suddenly. Shouldn't present totally unilaterally, but maybe it could be asymmetric early on. Wilson's can have any movement disorder. A wing beating tremor is the classic one where the tremor is most prominent in the wing beating position. Parkinsonism, I think dystonia, even chorea is probably possible as well, usually much younger patients. And there's a whole list. There's chorea, acanthocytosis, DERPLA, which is dentatorubropaludoleucian atrophy syndrome, Haw River syndrome. There's a whole list of degenerative chorea causing syndromes, but probably not the case here, right? Those are chronic. So subacute, acute to subacute, there's an inflammatory chorea called Sydenham's chorea, right? Caused by, I believe, group A beta hemolytic strep, part of the whole rheumatic fever type thing. We might not see this too much in patients who get quickly to antibiotics, but in many parts of the world, this is still common. Someone from medicine, correct me if I'm wrong, that it's group A beta hemolytic strep. And this is a chorea that comes from some post-infectious inflammatory process. There are a number of antibody syndromes in the sort of paraneoplastic autoimmune mediated category that can cause chorea as one of their features or the main feature. So anti-NMDA encephalitis, which usually causes a limbic encephalitis with psychosis, seizure. There's often orofacial dyskinesias. Some of those patients can have chorea as well. Anti-CRIMP5, it's a rare autoantibody that can be paraneoplastic or not CRMP5 that can cause chorea. There's a whole host of other ones. But those would generally be subacute in onset over weeks to months. So in this hyperacute acute, we're thinking of stroke. If this is not chorea 4 minutes, some other type of abnormal movement, it could still be seizure, right? And the toxic metabolic, so as I mentioned, when we're in this table, right, we're saying what neurologic diseases, so that's why we just talked about those. Structural lesions that can cause chorea, right? So does anyone know, Ravi or Lauren, a structural lesion that can cause chorea? I'll give you a clue to remind you that chorea is on the spectrum of athetosis and ballism. So hemichorea, hemiballism is part of a spectrum. Any thoughts on a lesion that could cause that, a structural lesion? And then we'll do systemic and drugs if you prefer to comment on those.
In the brainstem, perhaps?
Yeah, so brainstem usually will present with cranial nerve deficits and then long track signs, either or both, and depending on the level, alterations in level of consciousness. So brainstem wouldn't usually cause a movement disorder outside of red nucleus, which can cause the rubral tremor. Lauren, yeah, go ahead.
I want to say maybe a structural lesion near the basal ganglia.
100%, yeah. So with movement disorders, we're always talking about the basal ganglia. And the chat had one of the answers here. So the classic presentation, and this is often on the USMLE, but in real life, I think I've seen it once in 10, 11 now years, is the subthalamic nucleus, which is a nucleus that stimulates the globus pallidus interna, which is the inhibitory output of the direct and indirect pathways. So if you pull away the positive influence on the negative, if you remember that plus, plus, minus, minus, minus diagram that medical students do not enjoy learning for good reason, right, then you're sort of having hyperactivity of that circuit. So subthalamic nucleus, ischemic stroke or hemorrhage, can cause hemibolism, just sort of large amplitude, erratic movements on one side. But actually, you can get lesions in other parts of the basal ganglia that can do that as well. So that's the structural aspect to think about. Excellent, Lauren. Something in the basal ganglia, in this case, thinking stroke or hemorrhage. Systemic diseases that can cause chorea, I mentioned sort of earlier on, but we've talked about so many things I'll mention again. For unclear reasons, lupus or antiphospholipid antibody syndrome. As I said, not a systemic condition, but a state, systemic state of pregnancy can cause chorea gravidarum. There's sydenham's chorea, right, which is a systemic condition because it's due to streptococcal infection. There's antibody-mediated syndromes. And then in the metabolic category under systemic, we have to have hyperglycemia, as I mentioned, right? And that can also present with hemichorea for unclear reasons. Usually systemic etiologies of movement disorders, drug-induced tremors, for example, hyperthyroidism causing tremor, it's going to be bilateral because the systemic process is affecting the whole body. But hyperglycemic chorea for whatever reason is often hemichorea, hyperglycemic hemichorea. And this patient does have diabetes if they're not adequately controlled and they're moving towards a non-ketotic state for whatever reason that can trigger this interesting presentation. And then drugs causing chorea, some of the anti-Parkinson's agents by stimulating dopamine, I believe, can do it. Don't quote me on that. I think that's the case. And then cocaine is one that I mentioned as well, which can cause chorea. All right, someone put MPTP in the chat. That usually causes Parkinsonism, is my understanding, but you may be right about chorea. I haven't heard that. All right. So when we get to this physical exam, when it's a movement disorder, we've been physically examining the patient the whole history, right? Because a patient with Parkinson's, often we can see from the waiting room that it's starting to look like that. And sometimes the patient says they have a tremor. And while they're focused on telling you about the tremor, nothing is happening. And when they get into the history, you'll see the tremor emerge. So we're looking for these movements and trying to figure out what they are. So that's going to be the main thing we're interested in on exam. And then, of course, if in addition to abnormal movements, we're finding something else, are there other signs here that help us point to a structural lesion or general systemic signs that point us to an underlying medical etiology? So let's hear what you found on the exam, Gabby, online. Great. So I agree with you. This looks like chorea, right? It's irregular. It's of large amplitude. It's not as violent as bolism, which the patient can even sort of be throwing themselves out of bed. And it's not kind of sort of subtle athetosis. The boundaries between these can be hard to say. It's not purposeful, right? That's another category. Some tics actually look purposeful. The patient, is squeezing their eyes shut or kind of brushing their hair or clearing their throat. Can have an almost sort of purposeful. These are sort of random flowing, non-purposeful movements. So this does look like chorea. And was there anything else of note on exam, Gabriella? Weakness, sensory loss, ataxia, anything like that?
No, only this. The rest was normal.
And then for the history, you said acute. So was this instant in onset? Did the patient wake up with it? Did it kind of emerge over a few days? Were you able to give us a little more precision on time course?
She said, I think, I don't remember this information, but I think she said she woke up with this, but it was not so progressive. She thought it was acute.
So, okay, so she woke up with it.
But I'm not so sure. Okay,
not sure. So definitely not subacute or chronic. Between hyperacute and acute, little hard to say. Okay, so I think we're probably going to get close to our answer here. Ravi, I think Lauren was up first last time. So we have now acute, sudden or acute, we're not sure, onset hemichorea. What test or tests would you like to perform, and what are you looking for? And if you want to wager a final diagnosis of what we're going to see on the neuroimaging.
Yeah, for radiological testing, I would like to obtain start off with CT of the head. I'm looking for hemorrhagic stroke to rule out. That's or a fracture, the brain. Those are two things I would like to exclude.
Mm-hmm.
Second, followed by MRI of the brain. I'm seeking like a stroke, infarct. Probably the location, if it's the left limb. So I'm suspecting something in the right side of the brain, either cerebellar lesion. I'm sorry, yeah, cerebellar, yeah, somewhere in the right cerebellar that's where I'm looking for.
Okay, so right, if it's on the left side of the brain and if it's on the left side of the body and it's weakness or movement disorder, sensory loss, and the lesion is in the brain, it would be contralateral. If it was ataxia, that's actually ipsilateral in the cerebellum. And you're thinking this could be a stroke, and you'd like to get a CT to see if this is a hemorrhage. And it sounds like this patient presented after a few days, so we're out of our acute window. In any case. Lauren, what are your thoughts here? What would you like to do next, and what diagnosis are you thinking of?
Yeah, I agree. Stroke sounds most likely, but I'd probably still want to get an EKG, CBC, BMP, check her glucose, and potentially consider a urine drug screen.
Yeah, great. So we're not 100% sure on the time course. If this came on in an instant, it's a stroke, right? It's ischemic or hemorrhagic. If this maybe, one thing to know about chorea is until it's extreme or unless it's very sudden, sometimes patients don't notice it, especially early in Huntington's, for example. Patients will sort of just feel fidgety, or some people will say you look fidgety, and they'll say I didn't notice it. So if this is truly sudden, I agree with you. If this is truly sudden or acute hyperglycemia is also on the differential still, you might say, well, then we won't see anything on the imaging. Actually, interestingly, you'll often see T1 hyperintensity in the contralateral basal ganglia with hyperglycemic hemichorea. So that could be something to look for. If the time course is what we call pseudo-acute, right, that the patient has kind of had this, but it's just been sort of fidgety, and some patients with chorea, they'll actually incorporate it kind of into other movements. It's called parakinesia. And do we have time? Yeah, funny story. When I was in medical school doing my emergency room rotation, you had a couple of weeks and had to do a certain number of 8-hour shifts. And so to try to get them done and take more vacation, I did 8 hours on, 8 hours off, 8 hours on, 8 hours off, 8 hours off for a couple of days like that, which was obviously a very bad idea. And I got the worst sore throat, strep throat I had ever had. You could see my tonsils touching. On one of the ED rotations, one of the residents just swabbed me, but gave me antibiotics. And after that, I noticed some very subtle, funny movements where if I was putting on a shirt, there'd just be like a little extra flourish. And I would feel like, oh, I did that to be funny. I had a feeling as if I was doing it intentionally to be funny. People would say, oh, that was funny. What did you just do? Or I'd sort of feel my hand do something, and I'd kind of just incorporate it into another movement without even thinking about it. And I was a busy med student. I wrote to the person who gave our movement disorders lectures, hey, I think I'm having post-infectious chorea. What should I do? And he said, I don't do movement disorders by email. You'd have to come in and see me. And I looked it up, and it said it's usually a transient thing if you're treated early enough with antibiotics. And so it went away. But I had the experience of having the movement, and it's coming from your, excuse me, it's coming from your brain, right? So you feel like you did it, and you feel like you have to explain it. And I have a vivid memory of putting on a jacket or something, doing this, and someone said, what are you trying to dance like Michael Jackson or something? So, sort of this extra thing. And I said, yeah, just being silly. And then I finally it dawned on me, oh wait, I have a post-infectious chorea. And of course, all I had learned about was Huntington's and Sydenham. So I got very scared, but read about it, and presumably I just had some mild post-infectious chorea. I had forgotten about that until just now. So that would presumably be bilateral. Another etiology to think about if this is not truly acute, the reason I was telling that story, right, is because someone might not notice it or blame it on something else, and this has been going on, is a structural lesion in the basal ganglia. And actually, one of the pathogens that really likes the basal ganglia region is toxoplasmosis. So if you saw subacute or coming on over weeks to months, hemichorea or something like that, or a sort of hemi-body movement disorder, you would definitely want to think about toxoplasmosis. And so again, if this is pseudo-acute, that it sort of wasn't noticeable until it became noticeable, and we saw a structural lesion on MRI or CT, we definitely want to think about an HIV test and a CD4 count to see if this patient could be at risk for toxoplasmosis. But if this is truly acute, I think this is either a stroke, hemorrhage, or hyperglycemic hemichorea. If the acuity is not quite correct, then structural lesion we'd want to worry about would be toxoplasmosis, or rarely a tumor in that region, but often for whatever reason, these lesions are also going to affect the adjacent internal capsule, which is running right there through the sort of between the basal ganglia structures. And so there could be weakness as well, but not always. I like this deletion of the exam. We're just going to write hemichorea. That'll be our internist colleagues will laugh at us that our exam was just normal except hemichorea. But sometimes that's all you need to make the diagnosis. So I'm rambling on because I don't know exactly, because the time course is not clear. But I suspect this patient had an ischemic or hemorrhagic stroke. You might say if she had a hemorrhage, wouldn't she look worse? Not necessarily if it's a very small hemorrhage. And because it would probably be a hypertensive hemorrhage in this case, what we would be worried about would be a deep hemorrhage, which are often in the basal ganglia thalamus or deep white matter. So that would be a reasonable place for a hemorrhage. But she looks so awake, and we haven't heard that her risk factors are way out of control. So I'm going to wager on an ischemic stroke in the right subthalamic nucleus here. But if it was a hemorrhage, I would not be too surprised. And if it's normal and her glucose is 600, that is also on my differential. Good question, Gabby. So Ravi or Lauren, do you want to give us your problem representation, which is just sort of your one-liner you would put at the beginning of your assessment and plan?
Yeah, sure. My one-liner: a 68-year-old female with past medical history, significant for type 2 diabetes, hypertension, presented to our hospital with the acute onset involuntary movements of left limb.
Fantastic. Yeah, 68-year-old woman with vascular risk factors presenting with acute onset of left-sided involuntary movements determined on exam to be chorea or choreiform, or just 68-year-old woman with vascular risk factors presenting with acute onset left-sided hemichorea or chorea. Good. So what did you and your team do next, Gabby, and what did you find?
Okay, so we did some labs. Her capillary blood glucose was 176. Her A1C was 17.6. We did a CT scan and an MRI, and the MRI showed a high signal in T1 in lentiform nucleus and caudate in the right side. Also discrete diminished sign in the central region of the pons with restricted diffusion attributed to osmotic demyelination secondary to hyperosmolarity state. The final diagnosis for us was chorea secondary to non-ketotic hyperglycemia. We treated her with haloperidol and clonazepam, and she got a little bit better. And also we referred her to the endocrinologists, and they started insulin and to do a better glucose control.
Wow. So did you say her glucose at presentation was 176 or?
Yeah, but her A1C was very, very high. So
yes.
I don't know if it was the glucose was when she was she didn't eat, or if she was after a meal. I don't know, but the A1C was very high. So
yes,
we attributed to that.
Yeah, so the A1C being so high, right? Good point. 3 days before, it could have been 800 when this began. So great, great case, and the patient should in principle do better with better glucose control. You mentioned symptomatic treatment for chorea. You can consider antipsychotics. So remember, Parkinson's is not enough dopamine, right? And very crude here if there's any neurobiologists, but Huntington's is too much, right? So dopamine depleting agents, including antipsychotics, can be used. Tetrabenazine and deutetrabenazine, which are, I think they're VMAT inhibitors. They sort of inhibit presynaptic dopamine release, can be considered as well. But the main thing here is to treat the underlying condition. This is one to keep in mind because, as we've talked about a few times, when you see a movement disorder on one side, you're thinking structural, 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 right? When you're thinking bilateral, see a movement disorder that's bilateral, you think systemic, drug-induced, degenerative, but there are exceptions. And an important exception is hyperglycemic hemichorea, which is not that common, but a reason a patient can present with hemichorea, and some radiologists who don't know what the glucose is, if you don't tell them, might look at the scan and say, oh, there's some signal change in this region, the patient had a stroke. But the astute clinician will say, wait a second, this patient's sugar is off the charts, their A1C is off the charts. And look, it's not really obeying a vascular territory, it's actually selecting particular structures, the basal ganglia structures. So hyperglycemic hemichorea, my understanding is often reported with non-ketotic states, so very high glucose, but maybe this patient had this before they came to the clinic. Presumably with that A1C, right, the glucose has been at very high levels. The 176 would seem to me to be low to cause it, but maybe the hyperglycemic state was in resolution. Yes, Gabby, I see you have the images. We would love to see those. This is not a common thing to see. And so what you would look for on MRI, I don't know how sensitive this is, but often toxins cause symmetric signal change in the basal ganglia, but this particular condition, the classic finding is T1 hyperintensity in the caudate and putamen and globus pallidus, I believe. So
yeah, I only have the CT scan with me, but you can see here the MRI was pretty similar.
yeah, so Ravi or Lauren, so we're looking at a head CT here. So just like chest X-ray, left is on the right and right is on the left. The patient is lying down with their feet toward you. So well, I'm using my arrow, but you can't see it. But left is on the right, right is on the left. So we can see the lateral ventricles, right? And do either of you know, Gabby, can you put your arrow on the structure adjacent to the left lateral ventricle? Sorry, the right lateral ventricle right there. So does either of you know what structure that is? Which basal ganglia structure kind of follows the same anatomy as the lateral ventricle?
The caudate?
Yeah, that's the caudate nucleus, right? Good. And so what's out there a little more laterally? Lauren, do you know what other structures of the basal ganglia are out there laterally that are also bright? I'm sorry? What structures are in there? Do you know, Lauren? It's okay if not. Don't need to know which is which, but which.
I'm trying to remember. I'm thinking like putamen, globus pallidus.
Brilliant, you got it. So the caudate is right there next to the ventricle, right? And then between the caudate and the putamen globus pallidus structures is the internal capsule, that area that's a little darker, that's sort of coming in a V shape, yeah, and then comes up between them as well. And then the putamen and globus pallidus are sort of these nested structures. The putamen is the most lateral, and then medial to that is the globus pallidus externa, and then kind of nestled in that is the globus pallidus interna. And those are some of the main structures of the basal ganglia. I saw someone put lentiform nucleus and striatum. These are confusing terms. I think the striatum is the caudate and the putamen, and the lentiform nuclei are the putamen, globus pallidus externa, and interna, but they're all basal ganglia, deep gray matter structures. And that's what's important here. And they are hyperdense here, meaning that they are brighter. And what can be hyperdense on CT? We have some time, and neuroradiology is fun. So there's something else that's very hyperdense here. Gab, if you can put your arrow on it in the middle of this scan, at the midline, yeah, something else bright. So Lauren, Ravi, so in CT, we're looking at hypodensity, meaning darker, and hyperdensity, meaning brighter. Do you have a differential diagnosis for what's hyperdense on CT and what's hypodense on CT?
Yes, hyperdense on CT, as we can see, the bone is hyperdense, and blood. In addition, calcium.
Yeah. Fantastic. Yeah, so hyperdensity means just what it sounds like, more dense. So if you look at the scan, just the normal structures, right? The bone is the most dense thing. The darkest thing is outside the scan, that's air, that's super dark. And slightly less dark is the CSF in the ventricles, which is more dense than air, but less dense than brain parenchyma. So yeah, for hyperdensity, the big things are blood and calcium. And so what, do either of you know what Gabby is pointing at there in the middle there? That bright thing? There's no bone there, right?
Is it a cyst?
Not a cyst.
I was thinking a calcification.
It is a calcification. So the pineal gland is right at the midline there, and that tends to calcify with age. So that's sort of a midline landmark. And one of my mentors published a paper showing that the deviation of that structure from the midline can correlate with level of consciousness when you have herniation. A paper from many years ago. So the calcified pineal gland, right, is going to be bright, and blood is going to be bright, but not as bright. Those are the main things. You can get hyperdense tumors or abscesses that'll be a little bit brighter than the surrounding tissue, but blood, calcium are the main things. How about a hypodensity? Any thoughts, Lauren? Do you have a differential for hypodensity on a CAT scan of the brain?
Is it a tumor or a mass?
Yep, those are some things on the list. Other things to add?
I mean, like normal CSF fluid or cyst.
Yep, so CSF fluid
Laura
is,
says air, that's a good point.
yeah, so air will be dark. If you get the rare situation of an air embolism, you're going to see darkness as dark as the air outside the brain. But basically, hyperdensity is calcium in blood, and hypodensity is everything else. So an ischemic stroke will be hypodense because there's cytotoxic edema causing swollen cells, more water, right? Inflammation will be hypodense, like a demyelinating plaque or something like that. Tumor will mostly be hypodense because a lot of what we're seeing is edema, although lymphoma, which has a lot of little blue cells right on pathology, will often be a little bit hyperdense. So hypodensities are essentially everything that's not hemorrhage and calcium, right? So it's ischemic stroke, tumor, inflammation, infection, with exceptions on both sides. And it can be very hard to distinguish those on CT. If they fall into a vascular territory, that's easy. If they, so it sounds like an ischemic stroke, right? If they're hypodense, but respecting the overlying gray matter, so it looks like they're kind of this thing that's growing, but the overlying gray matter is preserved. It's usually not a stroke, because a stroke would not sort of accept those gray matter, white matter boundaries. It would just take out its whole territory, unless it's a very deep stroke, obviously not close to the cortex. But you have a lesion that's subcortical extending to the cortex, and it looks like it just stops at the gray-white junction. That's often tumor infection, inflammation, rather than ischemic stroke. So fantastic, Gabby. So you gave us the opportunity to talk about how to think about abnormal movements. We mentioned seizures. We mentioned movement disorders. I forgot to mention fasciculations, also abnormal movements due to muscle twitching. And we had this interesting presentation of sudden onset chorea, hemichorea, which has a pretty small differential, stroke and hyperglycemia. And this patient had risks for both. And we saw this very rare but unique sign of contralateral hyperdensity in this case, or T1 hyperintensity on MRI, contralateral to acute hyperglycemic hemichorea. What teaching points did you want to share with us, Gabby?
Well, thank you for the discussion and
for the case.
So I think the most important things here, when we see a movement disorder, we have to differentiate it between a movement disorder and a seizure. And it's also important to know the hyperkinetic and hypokinetic movement disorders. The hyperkinetic can be tremor, myoclonus, tics, chorea, athethosis, and valismus, and also dystonia. And the hypokinetic is usually Parkinsonism with bradykinesia. We always say that in neuro it's important to know the time course and the localization, but in the movement disorder, usually it's more important the type of movement disorder, more important than the localization, because most of them will be in basal ganglia. We also talked about a lot of causes of chorea because we saw the video and the movements were sort of choreiforms. And there are some acute, subacute, familiar causes, structural causes. And the last thing that we were thinking about was ischemic stroke and hyperglycemic chorea. And this was, we could differentiate between these two in the CT scan that showed hyperdensity instead of a hypodensity that we would see in a stroke. And also we could exclude hemorrhagic stroke. I think that's it. Thank you, Lauren and Javi and Aaron for the discussion.
Great, Gabby. Thank you for bringing us this case. Many things to talk about along the way. Hopefully people feel more comfortable with a general approach to abnormal movements. And when you see a movement disorder, remember it could be a neurologic disease, it could be a structural lesion, it could be a systemic condition causing that, and it could be medications, drugs, etc. And I will try to, when this goes out on Twitter, to tweet out a little tutorial about that and my mega table of all of those things. Brilliant discussion, Lauren and Ravi. Lauren, you said your neurology was rusty. It didn't look rusty at all to me. You had some fantastic discussion and some great points, and were able to identify individual basal ganglia structures on CT, both of you. So that's high marks in my book for sure. So hope everyone ended or at least diminished their neurophobia somewhat today, and look forward to seeing you next Tuesday. Please think about if you might like to volunteer. You have now more than 10 minutes to consider it. You have 7 days to think about whether you might like to volunteer. We would love to have you. And if you have a case you want to present, or if you'd like to discuss a case. And also this Sunday, if I'm not mistaken, is a student-only Neuro VMR, if my dates are correct. And so we'll be happy to have you there. No residents, no attendings, except me and Jack, just students. And we'll discuss a neurology case there as well. Thanks again, everyone. Thanks, Gabby. Thanks, Sukriti. Thanks, Lauren. And thanks, Ravi. See you soon.